We are going to talk about the Appendix 3 in the Green Top Guideline number 71, that is about the investigations and recommendations for pregnancies with suspected inherited bleeding disorders. So, here, right from the beginning of the pregnancy till delivery and postpartum, there are things that we are concerned about and investigations that we can do to optimize the delivery and pregnancy outcomes. So the first thing that we can do in these kind of pregnancies is right from the time of implantation in those patients opting for an IVF. So if there is a concurrent infertility or any kind of issue where an IVF is happening and the pregnancy has a risk for the inherited bleeding disorders, a pre-implantation genetic diagnosis can be done. And since we all know that hemophilia is a X-linked condition, so it mostly affects the male fetus. So in case the fetus is male and we have an option by pre-implantation genetic diagnosis, then we can drop the male fetus and not implant it, and we can selectively implant only the female fetuses. So from the time of pre-implantation genetic diagnosis, we can definitely do the gender determination and selective implantation of the female fetuses, and at times also genetic analysis for the causative hemophilia mutation, permitting the exclusion of affected male embryos. So we can do the genetic analysis as well as gender determination. Now, before moving on from this segment, there are a few basics that I'd like to discuss about this topic. When we're trying to investigate a pregnancy at a risk for inherited bleeding disorders, there are two things that we want to look into. First is the sex of the baby, and the next is the genetic mutation. Now, if we talk about cell-free fetal DNA assessment, then that is done mostly for determination of the sex of the fetus, because from the time of 11 weeks onwards, we have the possibility of doing a chorionic venous sampling and then an amniocentesis, which are much more diagnostic methods, and they're not screening methods like cell-free fetal DNA. So when we're doing a CVS or an amniocentesis, definitely we will be looking for genetic mutations. But if we are doing a cell-free fetal DNA in early pregnancy, that is mostly for the sex assessment. So it's very, very important to understand what are we trying to test. We're testing for the sex of the baby and the genetic mutation, and along with the CVS or the amniocentesis, we always do a cross-check with the genetic mutation study on the maternal blood sample as well. So maternal cross-checking of the mutation is also essential along with these tests which are done on the fetus and amniotic fluid. And one more important aspect of this investigation is this test is not applicable for multiple gestation, because of course we don't know what the sample that we have received in the cell-free fetal DNA definitely might be of any of the fetuses. So when we're talking about the multiple pregnancy, we will never do a cell-free fetal DNA. So this is in a nutshell about the determination of the sex and the genetic mutations. We all know that pre-implantation genetic testing is done before implantation. That can be done for both sex and genetic mutation. And CVS is done from 11 to 13 plus 6 weeks. Amniocentesis can be done from 15 weeks onwards, and it can be done up to 34 weeks. After that, the fetal cells in the amniotic fluid tend to go down. So it is always preferred to do amniocentesis by 34 weeks, where you can plan the delivery according to the at risk fetus. So if it was missed being done in the previous weeks of this gestation, you can do amniocentesis till 34 weeks. That is possible. And always remember to take a maternal blood sample along with the fetal sample that we're taking. And one more thing that is to be remembered, since cell-free fetal DNA is not a diagnostic test, it is a screening test mostly. So always the sex has to be reconfirmed by the 20 weeks anomaly scan. So the sex and the genetic mutation, this is something that we have to remember. So let's go into a revision. So when the baby is in the petri dish, it is the pre-implantation genetic diagnosis. We have to look for the sex of the baby and the genetic mutation and selectively implant the female fetuses. Now if you can see, this child is holding the balloon. That is the 9 weeks time when we will do the cell-free fetal DNA for the assessment of the sex. Now the baby is growing big. It is somewhere around 11 to 13 plus 6 weeks. So this is the time of the CVS. As you can see, along with the CVS sampling, we are also doing a maternal blood sampling. Then again, this is the 15-week sample. That is, we are doing an amniocentesis at 15 weeks, and alongside we can also do a maternal blood sampling for cross-checking the mutation. Always the baby's sex has to be reconfirmed by a anomaly scan, and if not done previously, then definitely we got to do a anomaly scan at 20 weeks to confirm the sex of the baby. Very important. And then at 34 weeks, we again, if we have missed doing an amniocentesis previously, or also for the clinical management of the childbirth, which has to be determined by 34 weeks. So this is the time for again amniocentesis. After this, the viable fetal cells in the amniotic fluid will go down. So this is our last golden chance to do the sampling and understand the mutations on both the amniotic fluid and a cross-check sample on the maternal blood. So this is very easy. Nothing much about this chart. We just have to remember the diagnostic tests which are possible. We all know about it. There's nothing new. And why and when are we doing it? And never a cell-free fetal DNA on a multiple pregnancy.